you whether you mind if I step in here and listen to your talk.
Oh, not at all.
I'll have to. Okay,
Be
great.
delighted.
I'm gonna get one chair and get out of the way.
Okay, I guess we'll get started. I'm Michael Whyte from St. Louis, Missouri, Washington University School of Medicine, and Shriners Hospitals for Children there. I became interested in bone disease purely by accident. Finished my first year at New York University, undergraduate chemistry. Thought I'd like to go to medical school. And in that era, probably getting a summer job that was somehow related to medicine seemed to be a good idea. So through my friend, who I think really didn't have any interest in medicine, he was lucky enough through his mother, who knew the wife of the professor at the Hospital of Special Surgery in New York City, to get a job, and I applied and I got one too. So as about an, 18-year-old, we were exercising rats running in a drum and cutting off legs to measure muscle mass, and then use Archimedes' principle. Remember, weight in air minus weight in water over weight in air equals density, as a way of exploring the impact of muscle on bone density. So this was long before we started putting cadaver arms into water baths and using single photon absorptiometry, which then became dual photon and DEXA, et cetera, et cetera. So I go back nearly to the Big Bang of bone densitometry and an interest in muscle and bone hypertrophy related that way. And that stuck with me, and sort of re-emerged, it was refined maybe, when I went to the NIH into a metabolic neurology branch, and there were inborn errors of metabolism, genetic disorders. So now I'm interested in bone genetic disorders a little bit. So where do you go? You go to St. Louis, Missouri, where there's Lou Avioli, John Haddad, Ted Hahn, and others to do bone research. And when I arrived, I must say, coming out of the NIH, where we took care of kids, and having an interest in genetic disorders, whereas the rest of the group in the Division of Bone and Mineral Diseases were adult physicians, it was very apparent that when we went out to Shriners Hospital once a month, that I might take over guiding the clinic, where we were seeing kids from not only Missouri, but the 8 contiguous states that were coming in just as outpatients with osteogenesis imperfecta, vitamin D resistant rickets, things like that. And luckily, in the early 1980s, the Shriners Hospitals for Children allowed me to recreate at their hospital what was then described as a General Clinical Research Center, GCRC, that I loved when I was a first-year fellow at Barnes and St. Louis Children's. With a 2-page consent form, I could admit families to either of these facilities or both simultaneously, and the NIH would pay for densitometry, bone biopsies, things like that. So I was very privileged to come out of an era of great nourishment for young investigators having those facilities. So now the Research Center at Shriners, the Center for Metabolic Bone Disease and Molecular Research, is 36 years old. And some of what I'll show you is from Shriners. Some of it comes from Washington University. But it's what we've encountered along the way. And I hope it's illustrative of how important studies of especially Mendelian diseases can be. The clues that they give you from etiology, and then hopefully pathogenesis, and pathogenesis, where you could then translate translational medicine, something that became a buzzword sort of 10 years ago. Well, take your knowledge and do something useful for the patients. So translational work is part of what we do as well. But to start with, I'll give you 2 quotes. One, both beautifully written, esteemed clinicians, physicians, one a little long-winded, but beautiful old English, each capturing the story that I want to tell you about. And this is William Harvey, 1600s. Do you know who William Harvey was? First group didn't get it either. This is the gentleman, I think a surgeon, who discovered systemic circulation of blood. So the heart pumps and the blood goes around. Pretty potent observation, pretty seminal observation. But he also knew this. He knew that nature is nowhere accustomed more openly to display her secret mysteries than in cases where she shows traces of her workings apart from the beaten path, nor is there any better way to advance the proper practice of medicine than to give our minds to discovery of the usual law of nature by careful investigation of cases of rarer forms of disease. I think if you wrote that sentence nowadays, submitting a manuscript, you'd probably run into a little trouble, but it's absolutely gorgeous. For it's been found in almost all things that what they contain of useful or applicable is hardly perceived unless we're deprived of them. A loss of function mutation, let's say, or a protein, or they become deranged in some way. So this is, again, a plea to pay attention to departures away from the usual. And Sir William Osler, who became the Regent's Professor of Medicine to the Queen out of Hopkins, said this: clinics are laboratories of the highest order. And at Shriners, on the corridor that would lead into the clinic, I put these sort of things to stimulate or hopefully push along the young investigators as they enter the clinic. The patients don't see it being on the other side because talking about the clinics as being laboratories they might not like. So I try to get this diplomatically done. But there's great truth in this, and I'll try to show you that truth. And I think from the experience from this morning session, I probably take you through the dense bone diseases. Too much of a bad thing or too much of a very good thing. Obviously, I can't begin to think I could touch on all of the genetic disorders, etc., but these are illustrative. And you've been hearing some wonderful lectures. Your plenary lectures, you might think are, gosh, they're pretty in-depth, they're pretty intense, things like that. Let me tell you, this is not primer stuff that you were listening to today. This is pretty state-of-the-art, complex, beautiful summaries. But you've had some very, very sophisticated lecturers who've contributed much. So we're going to do dense bone diseases. Too much of a bad or good thing. Is too much of bad bone bad? Yes, it is. Is too much of good bone sometimes bad? Yes, it is. But meanwhile, the bone could be bad quality or good quality. And Mother Nature's giving you examples of what happens if you underdo it or overdo it. So we pay attention to these. And if you are persuaded to differentiate, we hope, along the pathway of bones, metabolic and dysplastic bone disease, etc., and you have a bone clinic, you'll see something like this someday. If you're in routine endocrinology, maybe once in a career. If you're doing metabolic bone disease, maybe once every 6 months. But of course, the routine is the expectation that patients coming to you to be screened for osteopenia, osteoporosis, and you get this standard diagram to look at where you are with this particular patient, and you're looking for, well, where's the dot? Is it here? Where's the dot? And you wonder whether or not the machine has failed. Not at all. There's the dot. So this is dense bone. How dense could it be? Well, you know about maybe plus 1.5 standard deviations, T-scores, Z-scores, T-scores being good for young life, looking to see if you're drifting away from a good bone density. But you're not used to what you can encounter when you see dense bone disorders. So here, how's that for a T-score? Plus 22. This is one of my patients. Sorry. And a Z-score, yeah, it's a young person, so the Z-score is about the same. Here, you don't really care about the T-score. You don't, I think, expect that this individual with a T-score of plus 22 is somehow super protected against ever fracturing a bone. There's no guarantee, and I'll show you how something like that could give you bad bones, and something not quite so high can give you very good quality bone. But this is what you can encounter clinically, where the increase in total bone mineral content is 358%. So that's different from what you used to, and the software doesn't even create a box that's big enough to accommodate these numbers. So that's dense bones. And I point out to you that you can miss the idea that your patient has dense bones if you go to nothing more on the DEXA printout than where it is in relationship to the World Health Organization definition of osteopenia, osteoporosis. And if you look at the summary that's generated automatically by DEXA instruments, be they lunar or hologic, where they'll say bone density greater than -1 T-score, no increased risk of fracture. And they'll print that out with a bone density that's plus 22. So for years, after publishing in the Journal of Clinical Densitometry how DEXA instruments and the World Health Organization classification are misleading, trying to get it changed, neither WHO or the manufacturers have done anything to correct for you the notion that you could be dealing with something very different when bone density goes high. So this is still a -1 or higher, you're normal. Not in my world. And then in your world, you have to realize this, please, dense bone disorders. There are many, and over the years, maybe 20 years ago, this was the kind of classification that was out there for dense bone disorders. And for endocrinologists, there were some that were considered metabolic, like skeletal fluorosis. This may actually be the most common metabolic bone disease on the planet. If you took an exam, you'd probably tick the box. Osteoporosis is the #1 metabolic bone disease. We used to say Paget's was #2. Probably renal osteodystrophy in Western countries is now #2. But if you think of the world, the entire planet, skeletal fluorosis is enormously prevalent in places like India, Pakistan, China, South Africa. And it may be getting worse because as the planet dries up, you've gone from using surface water to drink to well water, good intentions about drilling wells to get to drinkable water that's no longer on the surface, it's contaminated. But down there, from volcanic rock, is where fluoride lies. So you could read in the Lancet a paper that we published a couple of months ago about a refugee from Kenya to Canada who came in achy with dense bones and came out of the Olduvai Gorge, a refugee camp, where they drilled wells, and one particular one went right down into fluoride-containing rock, and he ended up with skeletal fluorosis. And then, yes, dense bones, hypervitaminosis, A or D, hypoparathyroidism, pseudo-hypoparathyroidism, milk alkali syndrome. They're there in the world of the endocrinologist of 20 years ago. But what's happened, in addition to metabolic and others, well, these are metabolic, but there are others. There are indolent lymphomas that could give you dense bones, mastocytosis, indolent forms of multiple myeloma, myelofibrosis, Paget's disease, sarcoidosis can do it. You've got this in the world of endocrinology, but you didn't have this. And that is the world of the dysmorphologists, the clinical geneticists who 30 years ago might be talked about as dealing with funny bones, dysplasias. What are dysplasias? They're genetically based disorders of the skeleton with symmetrical abnormalities. That's different from a dysostosis, where it's one or a few bones that are abnormal. But here are dysplasias that cause dense bones, known to the radiologists and the clinical geneticists, let's say 30 years ago. So the naming was usually how they were inherited and what they looked like radiographically. So you had central osteosclerosis. Osteosclerosis I will define for you in a few minutes, but a density here with ectodermal dysplasia. Then you've got craniodiaphyseal dysplasia, so the head and the diaphysis, the shaft, is dysplastic and dense. And on you go down along Lenz-Mayewski syndrome, Sclerosteosis, here. And in that era 30 years ago, none of these was really understood at the etiological level, even though they were genetically based. But there's been, of course, a revolution in next-gen sequencing and the mapping and the candidate gene searches and more. So that I tell you now as a budding endocrinologist that the metabolic or the genetic basis, the etiology, therefore, of most of these are now known. So, doctor, here's my gene analysis. I have one of these. Here's the etiology. So what's my treatment? And for a few, you have insights about what has gone wrong pathogenetically, but not always. But these are the folks that are now going to be coming to you if you go into endocrinology and you're interested in metabolic bone disease. All of this is shifting in that direction. So you've got a lot of disorders heading your way. And these are just the ones that cause dense bones. So they're coming to visit you. So endocrinologists, I tell you that cumulatively, with all those disorders, the population is not few. They're all rare disorders. They're all orphan diseases. Everything that's cared for at Shriners, I think, is an orphan disease because there's less than 200,000 cases in the United States. That's how these are defined. And you're going to encounter such patients if you stick with metabolic bone disease. But dense bones are of two flavors, like I said, too much of a good thing or a bad thing. And there are those that I'll show you that are obviously of poor quality. Osteopetrosis, we're going to go from using this as a generic term to a very specific pathogenesis that you have to understand in order to deal with these folks. There's Engelmann's disease, progressive diaphyseal dysplasia, genetically based TGF-beta abnormalities. There's metabolic, dense bones, skeletal fluorosis. But then there's genetically good quality bone. And by good quality, you don't fracture. It doesn't mean you don't get into trouble necessarily by having too much bone, and I'll show you that. But endosteal hyperostosis. So what is hyperostosis? That's cortical bone thickening, and that's different from osteosclerosis, which is trabecular bone thickening. And then why is it called endosteal? It's because when the radiologist looked at the dense bones, the medullary cavity was narrowed, so it's at the endosteal surface. It's not on the surface of the bone, periosteal. And I'll show you sclerosteosis. You've been hearing about that, this rare disorder for some of the day, Van Buchem's disease. And something that was named by, or first reported in the 1960s by Dr. Wirth, known as Wirth-type endosteal hyperostosis. And this is the story of LRP5 and 6 and Wnt signaling that you heard about. But these are all endosteal hyperostoses according to the radiographic classification of years ago. I'll touch on hepatitis C-associated osteosclerosis, one of the disorders we bumped into in St. Louis. Separated by 2 months, 2 patients came in, I think both in their 30s, very achy, dense, bones, very dense bones. Then they didn't look like, as I'll show you, true osteopetrosis. And the common theme for both of them was they were IV cocaine abusers. So we thought for this disorder, and I'll come back to it, that it was somehow related to something that was contaminating their drug habit. But in order to understand the good and the bad bone part of this, you have to understand skeletal growth, because some of this is pediatric and some of this is adult. Adults are going to keep you down here. That's going to be remodeling. But a child grows, and the bones have to shape or model correctly. They're always remodeling. But after growth is done and modeling is done, you're remodeling. And you've heard the wonderful lecture by Dr. Seaman this morning about this. And John Belazikian just talked about remodeling and how you tackle it therapeutically. Cliff Rosen talked about some of the metabolic conditioners of remodeling. So skeletal formation, growth, modeling, and remodeling in a growing child. So this sort of captures beautifully endochondral bone formation. Endochondral meaning bone formation that comes from cartilage proliferation. And if you look here, this is the little kid's bone out to here, nicely shaped, distal femur. See a nice concave surface. This is shaped properly. That's modeled properly. It's growing because the cartilage is proliferating, and then the cartilage mineralizes and then turns into bone. But this pushes the bone in this direction. Inside, it's remodeling. But if all goes well, you develop the bigger kid bone, which looks like this. It's beautifully shaped. It's got a concave surface. And that's physiology. But along the way, this bone has moved through space in a way that you have this blue stuff on the surface. But that has to be removed so that the bigger kid bone has a nice concave surface. So whose job is it to get rid of the blue stuff? It turns out it's the job of the osteoclasts. And you have not a node of Ranvier, but a ring of Ranvier and encoche, which is a sort of, as far as I know, a band of osteoclasts that sort of scoop out the blue stuff. So you can imagine now what would happen if the osteoclast failed. I'm going to show you this in a minute or so. But that is the modeling of a growing bone, a proper modeling in a child. We talk about types of dense bones. This is really definitions before going further. Type of dense bones. It's not osteopetrosis. 40 years ago, 50 years ago, if you had a patient with dense bones and the radiologist saw it, they'd say osteopetrosis of the femur, osteopetrosis of the lumbar vertebrae, things like that. They were using it in a very generic sense. What I want to convince you of this afternoon is this needs to be applied with great precision. There's a unifying pathogenesis, and the therapy for these things that could be very, very wicked, the osteopetroses, depends on an understanding of why the osteoclasts don't work. And we'll incriminate the osteoclasts as we go along. But by definition, hyperostosis is cortical bone thickening, and osteosclerosis is trabecular bone thickening. Osteopetrosis in the old way is much too generic. And then you can get clues from the radiological descriptions of focal or diffuse dense bone disease that could be combinations of hyperostosis or osteosclerosis. So we move forward from those definitions. Here's a depiction of a normal bone. You need to know some anatomy here. You have the physis, that's the growth plate. You have above it the epiphysis or epiphysis. You have below the physis, the growth plate, the metaphysis or metaphysis. And then the cortical bone is the diaphysis or the diaphysis. So this is a beautifully normal, growing, healthy bone. Modeling defects can be of several types, causing radiographically, put up the X-ray, dense bones. So you can have a failure of removal of the blue stuff because the osteoclasts are not working. This is the Erlenmeyer-Flask deformity. This will give you dense bones. After all, this is a widened bone, and there's plenty of mineral in there. The radiologist would see it as a lot of white. This is undertubulation of a bone. It hasn't become a tube. Whereas here, if you did an X-ray, the radiologist may say it's a narrow bone, but it's very dense. It's a narrow osteopetrotic bone, not osteopetrotic. This is a radiographic result of overtubulation. It's too tubular. This is undertubulation. So you've got these kind of modeling abnormalities that could give you dense bones. And then you've got also proliferative abnormalities that can give you dense bones. You can have periosteal, now we're talking, remember, hyperostosis, cortical bone, that's on the surface. Or you can have endosteal hyperostosis, it's pushing from the cortical bone into the medullary space. So this is hyperostosis, cortical bone, and then you could have osteosclerosis, very dense trabecular bone, combinations or separately. And for many years, this is what guided us to thinking, oh, what does skeletal fluorosis give us? It's mostly axial. It's mostly osteosclerosis, so dense trabecular bone. There can be some cortical widening, but how does that differ from other things? So making a diagnosis purely radiographically was a great struggle, but much of that, as I'll explain, is over. So what is osteopetrosis in the modern era that you need to know about if you're dealing with patients? And that is dense bone disease of childhood. Adults, in a sense, don't develop osteopetrosis if the hit comes after the skeleton has fully grown. Osteopetrosis is a global failure of osteoclast-mediated skeletal resorption during growth, during infancy or childhood. Well, how do we know that? How do you know the osteoclasts aren't working? You start with this. This is Heinrich Albert Schönberg. He was a surgeon in, I think, Hanover, Germany, early part of the last century. He actually won a prize for his work, came to St. Louis, you know, the 1904 World's Fair. Meet me in St. Louis, and that's sort of thing. He won a prize from Germany because what did he do? He used a new technique of his era, and that was röntgenography, X-rays, to look at patients. And he did that for a couple of years. And then there was the annual, not the annual, but the monthly medical meeting. And he went to that medical meeting and told this story. This story is one paragraph, and down to here, it's the story of one man that'll have Albert Schönberg's name live forever. Because what is he saying in German here? He says, I did an X-ray of a young man who stepped into a pothole, and he broke his femur. And when I did an X-ray, he had very opaque bones. And when I X-rayed other parts of his skeleton, the bones were dense over there, and he had fractures that he really didn't know about. So that is the first description of osteopetrosis. It's based on an X-ray. And down here was probably the real hit of the medical meeting, because he talks about showing the X-rays or the röntgenograms of a mummy that the museum had just acquired. Nevertheless, that's the first description. He also noticed that when he did his röntgenography of his patient, he saw what we saw in the X-rays of a guy who was waxing the floors in Barnes Hospital, and the machine got stuck, and the handle came around and clipped his femur. He fractured it. But this is what Albert Schönberg describes and what we saw, and that is a undertubulated Erlenmeyer flask deformity, very dense bone, no medullary canal, and very interesting, sort of periodicity, dense, not so dense, so that if any one of you can figure out what was going on in Albert Schönberg's patient, where you can actually get rid of some of the dense stuff, you've got a treatment for Albert Schönberg disease, named for him, where currently we don't have one. But here's characteristic radiographic change of osteopetrosis. What is it telling you? It's telling you that when the bones look like this, the key features are no nice medullary canal, and the medullary canal should be the osteoclast eating away here to make medullary space. No medullary canal, and a widened Erlenmeyer flask undertubulated bone, which was then understood to represent what were being recognized then, the job of the osteoclast. That was the radiographic features. But the smoking gun, if I could use that expression, for osteoclast failure was provided by the anatomists who would look under the microscope at osteopetrotic bone. And what they saw was this: cartilage bars or islands of calcified primary spongiosa. So if you look at the metaphysis, maybe a centimeter or 2 centimeters away from the physis, the hypertrophic chondrocytes, remember, they rest, they hypertrophy, they mineralize, they form primary spongiosa, which isn't calcified, but then becomes calcified in that process. And then very rapidly, osteoclast should come along and remove the calcified primary spongiosa and turn it into trabecular bone. If you autopsy or biopsy the metaphyseal region of a patient with any of the kinds of osteopetrosis that I'll show you, you see cartilage bars. Here's a bar. It's this lightly blue-stained stuff. This is well mineralized bone. So that's a cartilage bar. Maybe that's a cartilage island. But it's showing you that endochondral bone formation worked okay. It made primary spongiosa calcified, but it wasn't resorbed. And that's the job of the chondroclast or the osteoclast. So this is failure of the osteoclast to resorb bone. And then in the 30s, 40s, 50s, you started to recognize that there were sort of 2 flavors of osteopetrosis. This is going to get more complicated. But an autosomal recessive malignant form, infantile osteopetrosis, and then an autosomal dominant, generation to generation, benign adult form of osteopetrosis. And that was the classification for many years. An intermediate form became known to us when, as a fellow, I encountered a sibship of sisters, 4 sisters. I guess this was the 1980s, and the oldest of them had suffered this fracture of distal tibia and fibula, and the bones were very dense. Look at that. So the parents were told, your daughter has malignant osteopetrosis, she will die. There was no therapy, but she survived. That's her and her affected sister and her other affected sister, who have some abnormalities with teeth becoming erupted, some deafness, blindness, sort of cranial nerve problems, and they're perfectly healthy sister as well. There were some unusual features about them, and that was the 3 affected sisters had osteopetrosis, even by biopsy, cartilage bars, renal tubular acidosis, so they've got a hyperchloremic metabolic acidosis. And it's a paradox. If you developed hyperchloremic metabolic acidosis, low bicarb, you'd leach mineral from your skeleton. Yet here they're acidotic, but they've got dense bones, and then still not explained, basal ganglia calcification, 3 sisters. Okay, so we're finishing fellowship, and we're an instructor now. Publish, keep going, keep going. Then another kid comes to us, and this was the brilliant mind experiment. This is pre-DNA, folks. Bill Sly, I asked him to see a child with osteopetrosis. He's chief of genetics at St. Louis Children's. He becomes head of biochemistry at St. Louis University. And I say, Bill, you know, this kid, could this kid have osteopetrosis, renal tubular acidosis? We measure urine pH, etc. But he takes out, what is it, Goodman and Gilman, the textbook of pharmacology. So being a geneticist, medical geneticist, he says, what could be giving you dense bones and renal tubular acidosis? So he reads about diamox and comes up with the notion that the underlying basis, the genetic basis of their disease might be a deficiency of carbonic anhydrase. Carbonic anhydrase hydrates CO2 to become bicarbonate in a proton for just let's say a proton, H+. So he's postulating that maybe these girls have a deficiency of a carbonic anhydrase. And Richard Tashian had developed assays of carbonic anhydrase 1 and 2 in circulating erythrocytes. So I remember drawing blood with Bill, sending it up to him, and a couple of weeks later he comes back and says, guess what? In those 3 affected sisters, there's absolutely no carbonic anhydrase 2. The healthy sister has perfectly normal levels, and each parent has half normal levels. So in the pre-DNA era, here's the first genetic basis for an osteopetrosis, intermediate severity, carbonic anhydrase 2 deficiency. So what does that tell you? The osteoclasts aren't working. Okay, we accept that, but why aren't they working? Well, you knew enough cell biology to know that in the osteoclast, they're putting out acid here. Mike Fallon put a probe into this area under the osteoclast and found that the pH was about 5.6. And in order to put out a proton, you need to hydrate CO2 so that you get bicarb and you get the proton to come out here to dissolve the mineral in the skeleton by what? Hydrochloric acid. These cells actually make hydrochloric acid. And if you can't make this, you can't resorb bone. The bone mineral, cathepsin K, and we'll talk about that, you heard about it briefly this morning, comes out in order to clean up some of the proteinaceous material that's liberated once the mineral is dissolved. So here you have an acidification defect causing osteoclasts not to work properly. And that grows over the years. Now you can do DNA. Now you can figure out the precise etiology of different types of osteopetrosis, all the common denominator, osteoclast failure, at least for this group. And you start with carbonic anhydrase 2 deficiency, but then TCIRG1, the most common explanation for malignant infantile osteopetrosis, is found to involve a proton pump subunit deficiency. So maybe if this isn't broken, you make the proton, but now you can't pump it. And if you're going to pump a proton to become hydrochloric acid, you have to pump chloride to get out there. And Albert-Schoenberg disease turns out to be chloride channel 7 deficiency. So it's all about acid, acid, acid. You go along and these other genes are playing a role. And then we have to come to this in order to think about how you treat these patients, and I'll come back to it. So it's acid, acid, acid. But then in the 1980s, using a great interest in dense bone disorders, but mostly radiographic changes, things got thrown off the tracks when, and I think this actually was on the endocrine boards a while back. It was thought that there's actually 2 forms of autosomal dominant osteopetrosis. Ironically, the investigators called Albert-Schoenberg disease the very first type 2, and they called another one type 1, again autosomal dominant, but this is, I'm going to show you, doesn't turn out to be a true osteopetrosis. It's from LRP5 activation and very good quality bone, very different. So there's only one human autosomal dominant osteopetrosis, and that is Albert-Schoenberg disease. And I stopped talking about ADO1 and 2 and talk about these patients have Albert-Schoenberg disease. The radiologists for those kind of studies looked at this, and they found that the folks that they thought had ADO1 were characterized correctly by a uniformly dense spine, thickened calvarium base of the skull, whereas Albert-Schoenberg has this rugged jersey spine appearance. You don't know rugby that much. I guess rugby jerseys have horizontal stripes. I guess the soccer players are vertical. So the radiologist said this is a rugged jersey spine, meaning thick end plates, and it was the density at the base of the skull that was characteristic. So radiographically, these were separable, but again, what was the genetic basis? Is this good quality bone or poor quality bone? That fellow who fractured his femur, like others with osteopetrosis, will break their bones like this. So straight across. It's like breaking a piece of chalk. Poor quality. This is a chalk stick fracture. Very characteristic of the cruddy bone that is underlying all forms of osteopetrosis. So why is it poor bone? Why does it break? And I was talking to Professor Seaman this morning, and well, there's defective modeling. If your bones aren't shaped properly, maybe that's structurally unsound. Widened bones can be stronger than narrow bones, but don't exactly know how to put this into that kind of context for predisposition to fracturing. But then it's probably not a good idea to have cartilage bars in your metaphyses. That's not good bone, so that could be explaining it. If your osteoclasts don't work, then your bones aren't being resorbed, and they're not forming so much, so the remodeling is slowed. And if it's slowed and your bones aren't disappearing and being reformed very nicely, those hydroxyapatite crystals are hanging around and they can harden. There can be hypermineralization of the hydroxyapatite in the sense itself, causing brittleness. Very importantly, though, you need osteoclasts to resorb bone, osteoblasts to put down bone. You know about cement lines between areas of resorption and formation. The collagen has to interweave in order to have a strong, resilient skeleton. So if you're forming bone and it's not interweaving, failure of osteons to interconnect surely accounts for some of the brittleness. And then if you've got all of this going on and you have a micro crack, then you're not going to have the osteoclasts around, to function to remove, let's say, a little bit of callus and repair this. So this is probably why osteopetrotic bone is susceptible to fracturing, but it's poor quality bone. But it's also a lot of it. It builds up. So what in malignant osteopetrosis? No medullary space. The canal doesn't form. So you understand the pathogenesis of what comes next. Leukoerythroblastic anemia. Very characteristic appearance on a peripheral blood smear. But ultimately, with extramedullary hematopoiesis, liver, spleen, these children will die of too little white cells, too little red cells, too little platelets. So all of that can fail. And the misery along the way is that the very dense bone is not crushing down on their cranial nerves. It's a failure of the foramina to widen. The osteoclast in the modeling should be making a wider foramen. And if it doesn't widen, the nerve grows and it gets pinched. So cranial foramina don't widen and you get cranial nerve palsies in malignant osteopetrosis. Nowadays, we know that 70% of all autosomal recessive is either autosomal recessive double hit, Albert-Schoenberg disease, 2 chloride channel 7 mutations together, or TCIRG1, the proton pump. This one is interesting because it causes an interesting bit of pathophysiology abnormality that you can understand, but you need to treat. If you don't pump the hydrochloric acid, you'll get the osteopetrosis. But this particular gene is also encoding the proton elaboration in gastric juice. So you don't have gastric acidity. You don't absorb calcium. So these malignant osteopetroses have a paradox of dense bones, but they also get hypocalcemic and rickets. The clasts don't work to get the calcium out of the skeleton, and the GI tract can't keep up. It malabsorbs calcium, so you get secondary hyperparathyroidism and rickets. And then you're faced as a clinician with, what do I do? This kid's got rickets and malignant osteopetrosis. You give some vitamin D, you give some calcium, you get rid of the rickets, but it sounds like you're throwing gasoline on a fire, although in a sense you're not. You're just handling one piece of the pathogenesis. Then you have this one, This one was out there, talked about very briefly this morning. Does anybody know who this is, who has pycnodysostoses? Any art majors before you got science? Who? Who? A writer? No, painter. Impressionist, the Belle Epoque. This is Henri Toulouse-Lautrec. And he was the little short guy who allowed his picture to be taken. We think he had pycnodysostoses, or let's say some do. Although 23andMe has never kicked in, none of his relatives have ever donated DNA to see if one of the two presumed mutations in what? In cathepsin K, the cleanup of the protein is defective, and you get dense bones. The radiography, the clinical appearance of pycnodysostoses when you're missing cathepsin K includes persistent wide fontanelle, so that's why people think he's wearing this hat. A small jaw, so that's why they think he's wearing a beard to cover that. He's got a cane, short stature. The average height is about 3'9", and Henri Toulouse-Lautrec suffered many fractures. So he's sort of the poster boy, ironically, because he's very famous for making posters of the operas in Paris, things like that, for pycnodysostoses. But this turned out to be cathepsin K deficiency. And if you look at the bones after all these years, yeah, that's a bit Erlenmeyer-Flask, that's dense. So here's a disorder that now gets fit into the osteopetroses. But here's the problem now. Now we've gone through the disorders of acidification. You've got cathepsin K. But these are disorders that can be solved by doing what? How do you fix the osteoclasts that don't work? They're there, but they're not working. Where do they come from? You heard that this morning. The osteoblasts are coming from mesenchymal cells. Where are the osteoclasts coming from? From hematopoietic elements, stromal cells. So if you want to fix these guys, you do a bone marrow transplantation. You put in the marrow precursors that will then generate into nice, healthy, acid-secreting osteoclasts, and you'll cure most malignant osteopetrosis. But then you were told about this morning. Remember the osteoblast talking to the class back and forth, and the osteoblast controlling the class by putting out rank ligand, a tumor necrosis factor, superfamily member number 11, and it binds to rank, this receptor here, to accelerate osteoclast activity. The osteoblast is also making OPG, osteoprotegerin, protecting the bone by doing what? Decoy receptor, dragging rank ligand away from its receptor, so quieting down the osteoclast. Well, if you've got defects in the genes that cause rank ligand to, responsible for forming osteoclast and chewing away on the bone, and the receptor's gone, then you don't make osteoclasts. So nowadays, in dealing with malignant osteopetrosis, you need to do a biopsy. Are there lots of effete but present osteoclasts, or are there none? Because these kids will not respond to bone marrow transplantation. So nowadays, molecular diagnosis, now based on your understanding of what goes haywire, is important for managing that disease. But that was Mother Nature doing its, should I blame it on Mother Nature? No, something went awry that led to humans having osteopetrosis. But then a boy was referred to us early 2000, and this is before you knew about, or we knew about, complications of aminobisphosphonate. You know the story of osteonecrosis of the jaw? In dealing with rarely patients who receive aminobisphosphonate, often if they have cancer or they're on glucocorticoids, can get a very terrible osteonecrosis of the jaw. And then have you heard about atypical femoral fractures? Yes, another complication that came along. But before these two were recognized as complications of bisphosphonate therapy or toxicity, this fellow gets referred to us. early October 2001. He comes down with a port because periodically he would have lower extremity sort of bone pain. He had elevated alkaline phosphatase, which to this date we don't actually have an explanation for. But in the era of enthusiasm for using bisphosphonates to treat osteogenesis imperfecta and its pain, this guy got an infusion of pamidronate, and then his pain went away. Then it came back. He got another one, and the docs who were taking care of him kept going and going and going and going, and then they finally said, this kid's gotten a lot of pamidronate, and sent him to us with that x-ray. And as best we could tell, looking at biopsies, MRI, CT, parameters of bone remodeling, everything, this kid had a healthy set of bones before he started getting pamidronate. And then after 2.5 years, look at this. This is a sort of a normal distal femur, proximal tibia, and then suddenly he starts getting blasted with anti-resorptives and ends up with a club-shaped, hyperdense bone. So this is now pharmacologic-induced osteopetrosis. And it's just a signal to you all that you now have anti-resorptives that are so powerful that if you overdo it in a child, you can do what only Mother Nature was able to do before. When this came out in the New England Journal of Medicine, it was, whoa, I'm not talking about industrial doses of bisphosphonates anymore for OI. We got to start looking at the growth plates and the metaphysis to see if cartilage bars are accumulating. And that's a separate story. So that's the first toxicity from aminobisphosphonate. This one's different. So we got dense bones. This is another story out of St. Louis. Very briefly, hepatitis C-associated osteosclerosis. I mentioned this to you. 2 patients come in, achy bones, but never fracturing, dense bones. And the common theme for them was not a family history, not too much bisphosphonate. They were both past IV drug abusers, cocaine. So I started calling the FBI labs and the street guys, the DEA in St. Louis, and you learn that cocaine coming in was cut with inositol. Nobody, I think, has ever thought inositol would cause dense bones. And then we learned that both were hepatitis C positive. And this entity does exist. There's only about 15 case reports, but it's hepatitis C-associated osteosclerosis, which is acquired painful diffuse osteosclerosis after IV drug abuse. And working with Sundip Khosla, Cheryl Canover at Mayo, what was noticed that in these patients they had elevations of an IgF precursor and a carrier molecule in combination, probably coming out of the liver, that was able to diffuse into the skeleton and cause dense bones. One of my patients, the bones look like this, but here's high quality dense bone, never pursued by any pharma company, but IGF-2E and IGF binding protein 2 in combination causing dense bones. So not everything that causes dense bones is osteopetrosis. In fact, look at these. Are we on time? How much time have I got left? What do you, 12 minutes? All right. You heard about sclerosteosis. That was the end of too much of a bad thing. Now we're going too much of a good thing. And when I say good thing, bad thing, it's the quality of the bone that's formed in the disorders. So now we got sclerosteosis. You heard that it's autosomal recessive. It's loss of function mutations in the SOS-SOST gene that does what? It encodes sclerostin. And sclerostin is a potent inhibitor of bone formation. So if you can't make an inhibitor of bone formation, you're going to make too much bone. And you're going to see a little bit more about Wnt signaling, etc. This is sclerosteosis. It has a sister disease, Van Buchem disease, where there's deactivation, so you knock out what? A downstream enhancer of SOST production. So you deactivate a downstream enhancer, it's not there to enhance, so you don't make SOST in Van Buchem's disease, or enough of it, and here you don't make it because there's loss of function mutations. And this is an extraordinarily rare disease, prevalent in Afrikaners in South Africa, Dutch ancestry. Both of these diseases were identified in South Africa, and the mutations worked out first in that population. Rarely it's found worldwide. And the only case I have ever seen came in with these x-rays. Look at how dense those bones are, but they don't fracture. This is very good quality bone. This is sclerosteosis, where there's something going wrong even in utero, such that there can be synostosis, fusion of bones or fusion of the skin, causing fingers to be like that. In Van Buchem's disease, you don't see the fusion. There is no synostosis. More mild, postnatal onset. But the bones look like this. The only patient I saw was from Saudi Arabia, an engineering student in Indianapolis who came to St. Louis to see me. That's his healthy brother. That's him with a kind of a prominent skull, who when he sees me looks like this. Broad forehead, he's got a Bell's palsy, and he's complaining about cracking headaches. And a chronically runny nose, and I thought for a second or two, well, we're at the epicenter of allergies. We've got the Mississippi and the Missouri and the Ohio floodplains, lots of fungus, and maybe his runny nose is from that. Wrong. He had a Chiari malformation, and the neurosurgeons realized that his brain was being crushed from exuberant bone formation on the inner table of the skull. Looking like this. Look at how thick that calvarium is, and you can imagine how it could be squeezing his brain. His pelvis is that, and that is just gorgeous bone. Wouldn't you want to do that to osteoporosis, you would think? Resistant to fracture. But here you have too much of a good thing, good quality bone. And sclerosteosis will, if not treated, at least neurosurgically, kill in the late 20s, early 30s. And you get all of these kind of problems. You get facial paralysis, not because the osteoclasts don't work to make the foramen bigger, but you've got anabolic effects of having no inhibitor. So now the foramen get narrowed because the bone formation is there. Cerebellar signs, Chiari-2 malformation, on and on and on, hearing loss, headache, etc. And then there's stuffy or runny nose. In osteopetrosis, malignant osteopetrosis, sort of the first clinical sign of the disease to parents is, my little baby seems to have a stuffed nose. And why is that? Because their sinuses don't form. Sinuses have to model, and you need osteoclasts to do that. So the kid's nose is full of bone. Here, you have stuffy nose, but you also have runny nose. And if I remember correctly from medical school, what are you dealing with? You're not dealing with a cold. You're dealing with CSF rhinorrhea. The raised intracranial pressure is pushing CSF down your nose. And I think you take a piece of tape and you look for glucose. If there's glucose, it's CSF. If it's this, it's a cold. You don't see glucose. So he had raised intracranial pressure, and 6 bits were broken in Indianapolis trying to get into the back of his skull to relieve the pressure for his Chiari. His bones look like that. That's the calvarium, and look at how thick and remarkable that is. But the bone quality looked, in a sense, swell. This is good quality bone, and these patients never fracture anything. So this is high quality, but too much of a good thing, and that is a bone disorder that's here. So then, yes, you've got the end osteal hyperostosis. You've got this one and that one. I explained that. I actually went to the FDA and I told them a story about what to watch out for with anti-resorptives, giving osteopetrosis, and too much of anabolics, potentially giving this. I don't think anybody's seen a hint of it, but here's Mother Nature giving you a warning. And in the last few minutes, Wirth type high bone mass. So we've done this one and we've done that one. Now we come to disorders of LRP5, 6. This is, remember, the autosomal dominant osteopetrosis, type 1 not. This is Wnt signaling enhancement. And Wirth type endosteal hyperostosis is not ADO type 1. It's LRP5 activation, LRP5 high bone mass. And this is the story that, who told it? Was it, I think, Cliff Rosen, about the family in Omaha, the ladies in the car crash. Her back hurts, they take an x-ray and there's no fracture. Instead, it's dense bones. They go around Nebraska, rounding up the family. And then they publish in 2002 this very interesting paper, a mutation in the LDL receptor-related protein 5 gene results in autosomal dominant high bone mass trait. And then they described this as non-syndromic high bone mass. It was wonderful. You had dense bones, car crash, nothing happens. Non-syndromic, nothing else wrong. Until, and then identified the mutation in LRP5, which was here in the first beta propella, the external part of an osteoblast on the cell surface. This receptor's out there. And the mutation is this missense mutation right in that one propella. Well, what does that propella do? It binds sclerostin. So if it's mucked up and it can't bind sclerostin, the inhibitor, it's going to drive what turned out to be then Wnt signaling to make more bone. But this was non-syndromic. And then later that year, Connecticut publishes in the New England Journal high bone density due to mutation, the exact same mutation, unrelated family. And they described their patients as syndromic. High bone mass, syndromic. Well, what's the syndrome? And in the New England, you might have seen this. Little one develops a broad jaw, has torus palatinus, little angle of the jaw, beautifully dense bones. So this then became syndromic. Here's a syndrome. Then this lady comes to clinic from Minnesota and tells me she's heading for Chiari repair. They're going to drill the back of her head for her osteopetrosis. But by now, I saw the torus palatinus. I knew this wasn't going to be Albert-Schoenberg disease. She has a Bell's palsy, had trigeminal neuralgia, had a hearing aid, and diffusely achy bones. So this is hardly non-syndromic or syndromic. This is disease. So if you overshoot with LRP5, good bone quality, you still end up in trouble. And we published her. She eventually had this removed to allow the Chiari malformation to be treated. But these disorders of high bone mass can give you disease. And it was interesting for us, if you read Bone, the October issue, so the next issue, the bone biologists have always thought that LRP5 and 6 are so-called cognate receptors. They do the same thing. At least they do the same thing in the test tube. But within the last year or so, we identified two kindreds living near Missouri who had mutations not in LRP5, even though they had torus palatinus, etc. So I'm challenging my colleague, Stephen Mumm, molecular biologist. Steve, come on, they've got torus palatinus, they've got all of this, they must have LRP5. So Steve says, I'll look at 6. And they have a mutation in LRP6 in the first beta propella in exactly the same sort of way that would impair sclerostin from binding. And when we looked at them by bone density, biochemistries, radiographically, you cannot tell these two apart. The only way you'll make the diagnosis of LRP5 and 6 high bone mass is to do mutation analysis. So in people now, there's validation of the cell biologist studies that suggested cognate receptors, and they'll do the same thing. This LRP5 or 6 overactivation leads to too much bone, but also it's a dento-osseous disease. It's not just bone, it's dento-osseous. And the dento is not just the torus palatinus and exostosis at the hard palate, but there's so much bone it forms around your teeth, and you can actually get your teeth encased in bone, sometime infection, as a manifestation of enhanced LRP5, 6 Wnt signaling. So this is an old cartoon. You saw some of it, but again, here's what's going wrong. LRP5, if it binds to a Wnt and frizzled-related protein as a receptor, will signal the osteoblast to make more bone. Sclerostin's job is to tease the LRP5 away and kind of modulate this, keep this from being overactive. If you have a mutation in the beta propeller or of 5 or 6, sclerostin can't bind, can't pull it away. It gets stuck there, and then you have too much bone formation. So this is the last two slides. The sweet spot in understanding genetic disorders that give high and low bone mass. Matt Warman and crew way out here. If you had autosomal recessive disease that knocked out LRP5, you got osteoporosis, pseudoglioma syndrome, a very terrible osteoporosis of childhood. So that's sclerostin, that's LRP5 knockout, no Wnt signaling. At the other end is sclerosteosis, too much bone with all of its trouble. Van Buchem's is here. Along the way, you can have multigenic or idiopathic osteoporosis, apparently for mutations in LRP5 elsewhere than that one beta propeller. So what this is telling you is that there could be a sweet spot of healthy, good quality bone, and you want to be drifting a little bit in this direction towards high bone mass phenotypes, maybe using anabolics, maybe using anti-resorptives, or maybe using anabolics to get you over here. Gain of function in LRP5 mutations of a mild degree, or as was explained to you, kind of a carrier for sclerosteosis, not a double dose defect, but just the right amount. And then anabolic therapies, you've had beautiful summaries at this meeting of the anti-resorptives, there they are. Then you've got denosumab taking advantage of the rank ligand OPG rank pathway. This one failed, trying to reproduce pycnodysostoses in a sense by a cathepsin K inhibitor. And now you've got the anabolics that are sort of exploring this sclerostin Wnt signaling pathway. So I'll stop here. And John gave me the title of genetic bone diseases. My gosh, we could talk about burosumab and FGF23 and XLH and how well that works. We could talk about hypophosphatasia, alkaline phosphatase deficiency, and many, many more. But I think just kind of going through what you learn by studying rare diseases can be very, very important to treating more common disorders like osteoporosis. So I stop here, happy to answer questions here out in the hall or at the poster session.
One question I have is regarding the LRP5 mutation. So we know it's autosomal dominant, and how about the heterozygous carriers? Because we heard it during our talks by Dr. Ansikian that you don't see.
Well, this is autosomal dominant. So these individuals with LRP5 are heterozygotes.
Right, sorry for the other one.
Sclerosteosis.
So I wanted to actually go towards chromosomizumab. So do you think sclerosis, right? We are targeting the sclerosis, SOST, and that's why we have the uninhibited effect from the wind signaling and bone formation.
Yes, you're not targeting, you're sort of trying to mimic it
Right.
gently.
So do you think that can lead to overproduction, like overformation as well?
We've never heard about it. I mean, by understanding these disorders, when clinical trials began, I'm not saying I was the cause of it. I think the field had understood that you could overdo it. With antiresorbatives, you could now mimic osteopetrosis, and with the anabolics, you could go too far. So I think the clinical trials involved maybe careful screening questions about cranial nerve palsy, things like that. So in a sense, I think they got it right, but you had these as cautions about not overdoing it. All right, if you want to chat, happy to do it. See you at your posters.